syntax 2 functional assessment of the stenosis in patients with multivessel disease. But first, let me tell you that the first study that actually explored the role of physiology in multivessel disease was the DEFINE study, which was actually the first study that truly demonstrated that the physiology-guided revascularization was far superior in terms of clinical outcomes than angiography-based revascularization. And we typically forget this, but this is a study on the physiology in multivessel disease. I'm not going to go through this because Patrick has already mentioned the big advantages that we had with physiology in terms of different patients in syntax 2. What I was very interested in seeing when Patrick was presenting the data at 3 years is that actually the safety of deferring in multivessel disease is still as good as it was at 2 years. There are no new revascularizations in the patients in whom the stenosis were deferred in syntax, so only 1% of the stenosis that were left untreated based on IFR and FFR, only 1% had a repeat revascularization as a consequence of stenosis progression. Now, why is also what I want to highlight is something very important. While it is true that all this speaks about physiology, this speaks predominantly about a newcomer in this area of physiology, that was IFR, because IFR was used to interrogate the stenosis and to make decisions in 75% of the syntax 2 study population. So, in a way, the syntax 2 study is a study that supports the value of decision-making based on IFR in the highest possible risk study or risk patient population. Now, subsequently to the syntax 2 study, we had the results of DEFINE-FLAIR and IFR SWEDEHEART that were looking to the safety of decision-making of IFR compared to FFR. And here you have a huge population, 4,486 patients of the 2 randomized clinical trials, leaving no doubt whatsoever that when you are making a decision based on IFR, you are actually making a decision as safe as you make it in FFR. And that explains why IFR or IWFR, as it shows in the clinical practice guidelines, has achieved the highest possible recommendation in the guidelines of myocardial revascularization. We still have the recommendation for FFR only for multivessel disease because of the legacy of the FAME trial. But the most interesting aspect of the 2 studies, DEFINE-FLAIR and IFR SWEDEHEART, is that they cause a whole avalanche of new non-hyperemic indexes. Suddenly, we have an avalanche of these indexes due to a number of reasons. It was due to the fact that IFR had demonstrated that it was non-inferior to FFR in decision-making, was faster, there were no discomfort for the patient, you have similar agreement with PET and other diagnostic tests, you perform less PCI than with FFR, something very interesting, 5% PCIs, but with the same clinical outcomes, most cost-effective, and the possibility of looking to serial stenosis because there is less crosstalk. And one of these indexes, actually a very interesting one, is the diastolic hyperemia-free ratio. It has many similarities with IFR. It is a diastolic index. As you can see here, this is the wave-free period that we incorporated in the IFR, in the original index. And what you can see is that the diastolic hyperemia-free ratio, DFR, is using as the window to interrogate or to sample pressure the segment that goes from the intercept of phasic aortic pressure with mean pressure, downslope, up to the last value that starts going upslope. And this is the segment of diastole that is being interrogated. And the index has been validated retrospectively using data from 2 studies, the Verify-2 and the Contrast study, and actually demonstrated a fantastic, superb correlation of values. So for the time being, we have, 2 diastolic resting indexes or better than resting non-hyperemic indexes that show a great correlation of values between both of them. I'm going to show you how it looks in clinical practice. We had the privilege of being one of the first centers in using it. And this is the way that you operate. You have a pressure guide wire, which is the COMET guidewire, that you can advance distal to interrogation. Immediately, you get automatic detection of the interval of sampling, this diastolic interval, and you can see here you get a display showing that this stenosis has a value that is significant. You interpret the same cutoff value like IFR, is 0.89. Any stenosis that is 0.89 or less, you shouldn't consider that is significant. In this case, you can see that it correlated very nicely with FFR. There is discrepancy in 20% of the cases, as you know, and we are understanding more and more why that happens. Actually, the reason why that happens is because FFR, from my perspective, is of course not an infallible technique. If you use a standard of reference, for example, PET, what you see is that the agreements between FFR, IFR, and DFR are very similar in terms of detecting stenosis that causes ischemia. And here you have this very nice study from our Korean colleagues, Jong-Myung Lee, Bong Kwon-koo, where they basically look to hyperemic myocardial blood flow and coronary flow reserve derived from PET, and you can see in blue and red those values that of IFR and DFR. Actually, this is DPR, which is a similar index. They did not perform it with DFR because it was not available to them. But it supports that diastolic pressure non-hyperemic indexes are pretty reliable in this regard. And they also look retrospectively, the colleagues from Asan Hospital in Seoul, they look retrospectively to the data they had in terms of clinical outcomes, reanalyzing their data, and they found that actually DFR, IFR, and FFR were identical in terms of predicting long-term outcomes. So which scenarios may DFR be considered over FFR? You should consider this as a sort of personal opinion. I think that for stable coronary artery disease, single vessel disease, we have a lot of evidence from the two big trials, DEFINE-FLAIR and IFR SWEDEHEART. I think that there is, provided that the patient is in a resting state, is not nervous, that there is no reason to believe that he's not fulfilling the conditions for a non-hyperemic index, it is probably, a very good choice. But if you move to multivessel disease, my opinion would be a definitive yes for non-hyperemic index to start with, because it is supported by the syntax 2 results that Patrick has shown us. It's obviously much simpler in a situation that you have to perform multiple measurements. You have to perform longitudinal mapping, which is, of course, much better with those indexes. And particularly, if you use proper guide wires that have workhorse characteristics, you don't need to change your guide wire. And that's the reason, because actually the COMET guidewire is a guide wire that has the ideal characteristics to be used in the context of complex anatomy. The tip has been designed by Asahi, that have a big reputation in terms of generating state-of-the-art pressure guide wires, and the torqueability and control of the wire is excellent. For left main stenosis, well, personally, for the time being, we do not have evidence supporting the use of non-hyperemic indexes in the left main, but I think it will be for a short time, because there are several studies upcoming that are exploring the use of non-hyperemic indexes in the context of left main coronary artery. So, to finalize, I have some final remarks. I think that the syntax 2 trial actually it's a study that has supported the use of non-hyperemic indexes in the context of multivessel disease, and is reassuring regarding the long-term result in stenosis that were deferred. The DFR index shows a very high correlation with IFR values. We need, of course, more evidence, more studies, but for the time being, we see that the values that we obtain with this index are virtually identical to the ones that we obtain with IFR. Although there are studies looking to repeatability of the measurements, etc., is certainly a great development. And final thing is that if you are using pressure guidewire interrogation to start with, as we did in syntax 2, in complex anatomy, in tight stenosis, you need very good workhorse wire characteristics, which are actually met with the COMET wire. Thank you.